Welcome to section 16 of the Falcon Physician Reviews. This time we'll be discussing the nerves of the upper limb as they relate to the brachial plexus and the associated injuries. This is a particularly befuddling area for some people, and it really will help you if you master the brachial plexus early in this process. If you have not mastered that already, spend some time ensuring that you understand that before proceeding. Now, if you think of the word plexus, it means to braid together. So the plexuses of the body are groups of ventral spinal segments that will braid together, and in this case they'll innervate the upper limb. I like to use patterns to remember the brachial plexus and draw it out a few times using these patterns, as I said, before you proceed. I like to think of the magic number 5, which is a handful of nerves are associated with the brachial plexus, and that number 5 reminds me that it starts with C5, 6, 7, 8, and T1. It has a pattern of 5, 3, 6, 3, 5, and if you say that out loud 3 times to yourself, 5, 3, 6, 3, 5, and then you can say it backwards, which is 5, 3, 6, 3, 5, that will remind you that it's got symmetry to it, that the proximal and the distal ends have 5 components, the central portion has 6, and then in between we have 3 components that we need to remember. Run to drink cold beer is the third image that I'll use to remind myself of the roots, trunks, divisions, cords, and branches that will go with that component of the pattern. And then finally, something that you can make an image of in your head is that my aunt's really my uncle. And those will be the beginning letters for each of the 5 terminal branches of the brachial plexus. So let's draw this out. We have a handful of nerves, which starts at C5, 6, 7, 8, and T1, ventral rami. We have a pattern of 5, 3, 6, 3, 5, and run to drink cold beer. The R in run is analogous to those 5 branches. The T in 2 is for the 3 trunks that we need to remember, which would be an upper, a middle, and a lower trunk. Notice how C5 and 6 come together to make the upper trunk, C7 stays on its own, and 8 and 1 come together to make a lower trunk. Again, we see symmetry when we draw this plexus out. Then we have 6 divisions. There will be 3 anterior. The first anterior comes off the upper trunk. Then there's a posterior off the upper trunk. The second anterior comes off of the middle trunk and a posterior off the middle trunk. And then we have a posterior off the lower trunk, and then finally an anterior off the lower trunk. The first 2 anteriors come together to make the first of the 3 cords, which would be the lateral cord. Then we have a posterior cord, which is the combination of all 3 posterior divisions, and it's named posterior because it sits behind the axillary artery. And finally we have the medial cord, which is really a continuation of the anterior division off of the lower trunk. Once we get past the cords, we'll discuss what comes off of those later. We have the 5 terminal branches. The 5 terminal branches are my aunt's really my uncle from superior to inferior. The first M is the musculocutaneous nerve. The A is the axillary nerve. The R is the radial nerve. The median nerve is the middle of that M shape that you can see that's made up of the musculocutaneous, median, and ulnar nerves coming together. And that final one, of course, my uncle, is the ulnar nerve, and that's coming off of the medial cord. Notice how the median nerve has a contribution from the lateral cord and a contribution from the medial cord. So when we think about the branches of the brachial plexus, we've just drawn out the basic foundations of the plexus, which we see that has symmetry. Now I like to go back when we're drawing the plexus and make sure that you understand which things come off each of those components. So what do we need to remember that comes off the roots? Well, there's a few things we could remember. We have the dorsal scapular nerve, C5. We have the long thoracic nerve, 5, 6, and 7 will fly you to heaven because it supplies the serratus anterior. And you could even include components of the phrenic nerve because C5 will contribute to the phrenic nerve for the diaphragm. If you're thinking about what comes off of the trunks, we have the suprascapular nerve, which is what's going to go to the supraspinatus and infraspinatus of the rotator cuff. We have the divisions, which don't have anything coming off of them. And finally, we get to the cords, which are the hardest components to remember. But again, I have a pattern that I want to remember, which is 2, 3, 4. If I start from the top with the lateral cord, it has two things I want to remember: a lateral pectoral and a lateral contribution to the median nerve. The posterior cord has three things that I want to remember. It has an upper, a middle, and a lower subscapular nerve. Remember that the middle subscapular nerve is also known as the thoracodorsal nerve, which will go to latissimus dorsi muscle. The upper subscapular and the lower subscapular will supply the subscapularis muscle, and the lower will then also supply the teres major. There are four things I want to remember coming off the medial cord: a medial pectoral branch, the two branches to the cutaneous medial side of the arm, so we have a medial brachial cutaneous to the arm and a medial antebrachial cutaneous to the forearm. And finally, we have a medial contribution to the median nerve. And then we have our 5 terminal branches, which we've already discussed. When you think about the sensory distribution to these, remember we're going to have dermatomal distribution and cutaneous distribution. C5 will distribute along the shoulder. C6 will distribute along the thumb and onto the index finger, and oftentimes that can be C7 as well. The middle finger will be C7 for sure, and C8 will distribute to the 4th and 5th fingers, finally with T1 being a strip of skin that gets up in towards the thorax and the axilla, and sometimes you'll even have some C2 coming into the floor of the axilla as well, and that T2 segment will actually be the one that refers pain from the coronary or myocardial infarction. When you look to the left of this, we have a posterior and anterior view of the patch distributions, which we know are going to be cutaneous. These are going to be sensory deprivations that are damaged when there's something that's hit after the plexus has braided together, whereas those dermatomal strips will be something that's affected when there's a more central lesion. There's the axillary, radial, musculocutaneous distribution, which will become the lateral antebrachial cutaneous, the superficial radial, which will do the dorsum of the hand, and notice how it comes on just around the edge of the heel of the palm, so it's never a good idea to test that heel of the palm for sensation, assuming that it's going to be median when in fact it could be superficial radial. Then we have the ulnar. Notice how the ulnar has the dorsal component, which comes off before the wrist, and then it has a superficial component which comes off after the wrist. So we have a superficial ulnar supply and a dorsal ulnar supply. The other important thing to notice is that the median nerve and the superficial ulnar are the ventral supplies to the fingertips, and embryonically the nail beds develop from the ventral surface, so they drag the innervation from the ventral surface around as well. So all of the tips of the fingers are the same as they are on the ventral surface or the flexor surface. Then we have our medial antebrachial on the forearm and our medial brachial cutaneous on the arm. Let's do a question. A boy fell from a tree and sustained a penetrating wound to his axilla. He's able to extend and pronate his forearm normally, but flexion and supination are greatly weakened. Which nerve has been most likely damaged? In this question, the musculocutaneous nerve is the nerve of choice. Flexion of the elbow is going to be from the anterior flexor compartment of the arm. And supination is the job of two muscles, the supinator and the biceps. And the biceps is going to be by far the more powerful of those two as a supinator. So with weakened supination, there's only a couple options that can be missing. One is the bicep, the other is the supinator, and if it's greatly weakened, it has to be the bicep, which is also innervated by the musculocutaneous nerve. The axillary nerve does not cross the elbow. The median nerve does nothing before the elbow. The radial nerve is an extensor nerve, and the ulnar nerve is only going to supply a couple muscles in the forearm. Let's look at some of these myotome and dermatome distributions. The C5 nerve root is going to distribute motor to the deltoid, so it can be used to test the C5 myotome. The biceps tendon reflex will test this neurologic level, and then the sensation that we talked about on the lateral side of the shoulder can be used to test C5. As far as C6, the wrist extension will test C6. The brachioradialis tendon reflex can be used to test this root level, and then the sensation would be onto the thumb and potentially the index finger as well. The C7 myotome and dermatome would be testable through motor wrist flexion, through the triceps tendon reflex, and then through the sensation of the middle finger. C8 and T1 myotomes and dermatomes are a little bit different. The C8 segment can be tested with finger flexion, but there's no reflex that can be tested to clear this root level, and the sensation would be on the ulnar side of the forearm and hand. The T1 distribution motor would be the interossei muscles, and the reflex again is nothing that can be tested, but finally the sensation would be up in the medial side of the arm and into the armpit. So in words, this is basically talking about the different levels and how they can be cleared. We really won't spend time on this, although those that like words as opposed to pictures can use this to go through these tests. When we talk about nerve injuries, we have general approaches. We always want to start distally. Are there any sensory issues? Is it a strip or is it a patch of deprivation if I do have sensory issues? Is there a bilateral or unilateral injury going on? What's the timeline? Is it fast or is it a slow timeline? Faster timelines may indicate vascular issues. Slower timelines may indicate disease or more degenerative types of issues. Is it normal, weak, or paralyzed when comparing the motor strength to the other side? How's it presenting, which is different than understanding what it can actually do or not do? And what's missing? If there's something missing, the unopposed function should take over in general. So what would take over? Think about if something's missing, what is the antagonist? And what are the possibilities and how do I rule them out? And this is where a differential between what nerves it could be comes in handy as you learn these things. And finally, think anatomically. Are there special tests and is there imaging that can help me make my differential diagnosis? So this is going to be the way that you can approach the distribution of these nerve problems. Let's try one. Following recovery from surgery for removal of her right breast, a radical mastectomy, a woman noticed that she had trouble raising her right arm above her shoulder and that her right scapula appeared to be jutting out abnormally. Which nerve was damaged during surgery? In this case, long thoracic nerve is the injured nerve. The long thoracic nerve runs along the superficial surface of the serratus anterior along with the lateral thoracic artery. It can oftentimes be injured with crutches or heavy backpacks or through surgical procedures such as the one mentioned here. When the long thoracic nerve is injured, they can't abduct past the horizontal or past 90 degrees because they don't have the serratus and the trapezius muscles to help with those thoracic movements and rotations of the scapula. The suprascapular nerve is going to be an initiator abduction and does not have the strength to abduct to 90 degrees. The thoracodorsal nerve is going to the latissimus dorsi, so it can't be that because it's a medial rotator and adductor, not abductor. And the axillary nerve is going to the deltoid, which is also going to be a major abductor. But the fact that they can get to 90 degrees means that the deltoid must be working. And the key red flag in this one as well is the jutting of the scapula. As far as the types of injuries, you can look at the avulsion injuries, which would pull the roots right out of the spinal cord. This is often the case with some of the Erb's palsies that are occurring during childbirth. These are oftentimes at fault when Horner syndromes occur and it pulls out the T1 nerve root. There can be rupture where the nerve itself is stretched, but not at the spinal cord level. There can be a scar or an compression around it, which would be a neuroma. And the neuropraxia or neurotomesis would be a result of the nerve being crushed or cut. Now, in another example, if a person is following a bull riding accident, a 31-year-old patient has difficulty extending the shoulder joint, abducting it to the horizontal plane, and extending the elbow and wrist joints. Which nerve structure has most likely been affected? Well, what you can do first is go through a question like this and start adding up what kinds of compartments are being done. So we have extension, abduction, extension of elbow and wrist. So there's a lot of extension going on. And automatically I start thinking of the radial nerve because it is the extensor nerve of the brachial plexus. And now we have to start saying how far back does this go. So we have two components of the radial nerve. We could either do the radial nerve itself, or we could do the axillary nerve, or it could be the combination of the two, which would be the posterior cord. If I include the fact that abduction is done, I know automatically that the axillary nerve is involved. But if I have extension of the forearm and the shoulder affected, that means I have to be back to the posterior cord of the brachial plexus already. Now let's look at the nerves as they come through the distribution of the upper limb. The musculocutaneous nerve, remember, is going through the coracobrachialis, then it lies between the brachialis muscle and the biceps, and then it becomes the lateral antebrachial cutaneous nerve of the forearm. The median nerve is going to stay in the brachial sheath and just pass through the arm on its way to the forearm. It crosses the elbow in front of the joint itself, remember, as a component of that lactan of the cubital fossa contents. It is susceptible to axotomesis through a needle puncture or through stretch injuries of upper limb injury. It starts distributing power muscles to the flexor forearm, where it does most of its distribution, and then it also controls the thumb. The ulnar nerve will start in the sheath and also just pass through the arm. It will then pass behind the elbow joint by going into the cubital tunnel, and it will supply 1.5 muscles, so not very many flexors of the forearm, but it'll have great responsibility for most of the muscles of the hand. So it is a fine movement control nerve of the palm of the hand and not a power producer like the median. It will supply 1.5 fingers on the hand for sensation and 1.5 muscles in the forearm for flexion. Injuries of individual nerves can occur in all sorts of different things, and we'll just try to highlight a few different ones. The suprascapular nerve, C5 and 6, can become entrapped at the suprascapular foramen, and this can cause initiation of abduction problems and also lateral rotation because it takes out supraspinatus as the initiator and infraspinatus. Now, it's important to remember that a patient will actually still be able to engage the deltoid, so you would think they wouldn't be able to abduct at all since they can't initiate, but they find ways around this by either rotating and using the deltoid or popping their arm with their hip to get it to the point where the deltoid can be engaged. The long thoracic nerve we talked about with the compression possibilities of backpack, crutches, or passing out on a chair one night where it can be deadened, and that will give you winging of the scapula. Thoracodorsal nerve, or middle subscapular as it's sometimes known, is going to be a great reduction in adduction and medial rotation because of the huge latissimus dorsi that it supplies being lost. Again, this muscle can sometimes be damaged because of the improper crutch walking, or during transfers from wheelchairs where it just gets torn. The musculocutaneous lesions can occur at the lateral cord, and it's going to greatly weaken flexion and supination, as we discussed in that earlier question. The axillary we talked about with surgical neck fractures, and it's important to know that when there's a dislocation, that shoulder will be in a inability to abduct it, and they're going to have the flattening of that contour again, similar to what you would have with a dislocation of the shoulder, but very often the person will know right away that they fractured it. So now we can look at some of these nerves in the posterior arm. We have the axillary nerve coming through the quadrangular space along with the posterior humeral circumflex artery. Remember, that's going to be doing the deltoid and teres minor. We have the radial nerve that's going through the triangular interval between the long head of triceps and lateral head of triceps, and it'll go into the spiral groove where it's susceptible to fracture injury along with the profunda brachii artery. And then we can also see a couple other nerves in here, which will be the radial nerve dividing at the spiral groove to supply brachioradialis and extensor carpi radialis. So if it's damaged before this branch comes off, then you will not have a true wrist drop in a damaged radial nerve, because there's some extension that can occur from extensor carpi radialis longus and a little bit through brachioradialis. We also have the suprascapular nerve, which is going to be from the upper trunk, and it's going to do the greater scapular notch through there to supply the infraspinatus after supplying the supraspinatus. Finally, we have dorsal scapular nerve, which is running the medial border muscles, including levator scapula, rhomboid minor, and rhomboid major. After the radial nerve gets into the forearm, it's already supplied two of the forearm extensors, one of which is actually a semi-pronated flexor, the brachioradialis, and the other which is the long extensor carpi radialis muscle. So it's going to divide into a posterior interosseous branch, or a deep radial nerve. Once it's in there, it will supply all of the extensors of the forearm. As I said, if this posterior interosseous nerve is damaged, you really don't end up with a true wrist drop injury. So it does produce variable paralysis to the extensors of the arm and forearm depending where it's injured. If it's above the deltoid tuberosity, there's a chance that triceps may be knocked out. If it's into the posterior cord, they'll definitely be knocked out. It will produce only small sensory losses over the posterior lateral aspect of the hand through the superficial radial nerve. The IP joints will still be extendable because they can be extended from the flexor surface using the lumbricals interossei. So the fingers can oftentimes still be extended even with the loss of a posterior cord or a brachial plexus injury to the radial nerve. If there's a radial nerve injury in the arm, it's typically from that humeral fracture, and you'll have to decide whether or not the triceps are intact as a key red flag component of the questions that you'll be doing in your step 1. Radial nerve injury at the cubital fossa will then involve something as along the lines of supinator entrapment, or hypertrophy or scarring from a fracture of the neck of the radius. These can all entrap that nerve, and that's going to spare the muscles that are attaching on the humerus, but it's going to affect the extensors that are in the forearm itself. That's why it doesn't cause a true wrist drop. The posterior cord, on the other hand, if there's a damage there, will cause a true wrist drop, as well as a shoulder that's adducted, since the abductors have been lost. So for posterior cord, look for axillary and wrist drop signs. Another question that we can look at. A patient arrives at the ER after falling out of a tree. They complain of pain in the left forearm that radiates to the cubital fossa. You see bruising and expect a fracture, but prior to sending them for X-ray imaging, your physical exam reveals flexion weakened at digits 1 through 3. and weakened pronation of the forearm. The patient is unable to make the OK sign with their thumb and index finger. What nerve is likely damaged? Well, there's a couple red flags in this particular question. One is that there's damage to digits of 1 through 3. That involves the thumb and the index and the middle finger. So we're not thinking about the ulnar distribution in the forearm, but we do have to think about forearm muscles because the digits are supplied by forearm power producers. So whenever you see digital weakness, you have to have something going on in the power producer region, which is the flexor compartment. Now, that means that the pronation has to tie into this, and another red flag is the OK sign. That OK sign using the thumb needs the distal phalanx to be functional, which would mean that the flexor pollicis longus must be knocked out. And what do we see here? That this must be the deep muscles of the forearm that are affected, meaning the anterior interosseous nerve is knocked out. What would this do? Well, the anterior interosseous does not supply the profundus tendons on the ulnar side. It only supplies the radial side profundus tendons and the flexor pollicis longus, and that would be enough to create the problem with the OK sign. If it were posterior interosseous, there would be extension problems, same with radial. If it were the ulnar, there would be medial compartment and medial digit problems, and if it were recurrent branch of the median only, that would mean that the flexor pollicis longus tendon would still be functional, and there'd still be the possibility of making the OK sign, even though the thumb would not be quite as mobile at doing it or have as much power. When we look at the median nerve in the forearm, here you can cross and follow its path as it gives off its different branches. I think we've discussed this enough that you can look through this on your own and make sure that you understand the pathways. Injury to the median nerve, of course, is going to cause problems if there's a supracondylar fracture in the humerus or a laceration or compression in the carpal tunnel. It's one of the most commonly entrapped nerves because of the carpal tunnel syndrome. At the wrist or in the palm are different portions of what's going to be happening. If there's a wound to the thenar muscles only, then there will be an inability to oppose the thumb and weakened flexion of the thumb, but not lost flexion because of that muscle in the forearm. So a palmar laceration may cut the recurrent median nerve, and this will have a similar effect, except that there'll be an effect on the tendon strength for the flexor pollicis longus with the carpal tunnel that you don't have with the cutting of the recurrent median. The thenar eminence atrophy is going to be a sure sign of a median nerve problem. Anything going wrong with the thumb, you automatically think of either the outcropping muscles in the extensor or the median nerve. There's a lot of sensory loss because you lose 3.5 fingers of sensation on the flexor surface because of median nerve loss. And you can use the Tinel sign by tapping over top of the carpal tunnel to elicit a electrical shot that will go through and along the path of the median nerve distribution. If it gets entrapped at the elbow, there's going to be additional deficits to those that would be at the wrist because you're going to lose a lot of the power producers. And the loss of pronation will be affected as well. So you'll lose wrist flexion, pronation, and abduction of the wrist because of the loss of those forearm flexors. You will also have an inability to flex the thumb and digits 2 and 3 at the IP joints, so you end up with what's called the hand of benediction. Remember, the hand of benediction only occurs as you try to flex, so it's an active movement that makes that sign. If you have a pronator teres syndrome, that's an often entrapped region of the median nerve, and you get a lot of these same issues going on. Again, the anterior interosseous nerve is key for making that OK sign. although the OK sign can be missing in addition to pronator teres syndromes and whatnot. Here's the ulnar nerve distribution. I'm going to just leave that for you to look at as it comes behind the cubital tunnel and into the hand. It crosses into the hand using the ulnar tunnel and does not go through the carpal tunnel. It's oftentimes entrapped at either the cubital tunnel near the medial epicondyle, or it can be entrapped as it crosses into the wrist. One of the key features to tell the difference between these two is to know whether or not there's dorsal sensation on the posterior ulnar half of the fingers, because that dorsal ulnar branch will be affected if it's after the muscles have been innervated from the forearm, but before that dorsal wrist branch has crossed. Now, injury to the ulnar nerve can frequently be caused by medial epicondyles, cubital tunnel entrapment, or at the wrist in Guillen's canal. And this just talks in words about what we've been discussing as far as the inabilities that you have. What I want to draw out is that you can have a claw hand, which is characterized by wasting of the hypothenar muscles, the hyperextension of the MCP joints, which causes passive flexion of the PIP and DIP joints of fingers 4 and 5 only. Since the median nerve is still intact, digits 1 and 2 work fine. This will produce variable paralysis in individuals who have median ulnar communications, which is called the Martin-Gruber anastomosis in the forearm. This can sometimes be cut in surgeries and will actually have some sparing effects for some people with their claw hand. If it's at the elbow, you'll have additional deficits to what you see with the claw hand because you're going to be losing some of the flexor strength in the forearm. And this will also impair ulnar deviation and flexion at the wrist. Now you're going to have an inability to flex the DIP joint because you've lost the ulnar half of digits 4-5 flexor digitorum profundus muscle. Let's look quickly at a couple of the Waiter's tip injuries, which is called an Erb's palsy, which is a upper brachial plexus injury, oftentimes associated with obstetrical injury. And this is an item that's commonly tested on boards. Here you can see an infant that has bilateral Erb's palsy or Waiter's tip. And one of the ways that you can remember this one is that it's Sam the waiter wants a tip. And that's just a memory aid to assist you with the idea that the suprascapular, the axillary, and the musculocutaneous nerves have been wiped out. There are other nerves that are affected, including radial and median, which can be weakened from this type of injury, depending on the severity of it. But these are the ones that are taken out of the scenario. So you start to lose the ability to abduct through the suprascapular and axillary. You have an effect to the lateral rotation as well. You have an inability to flex the elbow, therefore you end up extended like this little infant is, and you end up medially rotated because a lot of your medial rotators are still strong, but your lateral rotators have been made weaker. You lose elbow flexion in the anterior compartment, and you also lose significant supination. So you end up in a pronated position. Here you can see a lower brachial plexus injury, which is also known as Klumpke's palsy, and this is giving you an ulnar clawed hand. Notice the hyperextension at the MCP joint. This is typically a C8-T1 root problem or avulsion from the spinal cord, and you're going to have the supply of the ulnar and the two medial brachial antebrachial cutaneous nerves, as well as the contribution to part of the median and radials. The same ulnar presentation occurs that we've already talked about, except you have a little bit of sensory loss because you're going to have more medial arm affected by this as well as forearm, so this will increase your suspicion because you'll have strip deprivations, which is before the plexus braiding. Also have weaker extensor muscles than you would in a regular ulnar claw just alone without the whole Klumpke's palsy. This is going to give you less recovery in the real world than typical upper brachial plexus injuries, which from that infant in the other page, you can oftentimes get good recovery from that. So here's a couple summary pages to compare them, where you have radial nerve wrist drop from an extensor injury. That's got to be above the deltoid tuberosity. And then you can see a median nerve injury, which gives the sign of benediction, but I want you to remember that this one is because of movement while you're trying to make a fist. It looks like this. Dupuytren's contracture is similar in appearance. The difference is that there's no metacarpal phalangeal joint or MCP joint hyperextension. This is simply because the flexors have shortened through a shortening of the tendon itself, oftentimes from injury or inflammation, infection, and they can't be extended. With the ulnar nerve injury, again, it looks fairly similar, but you have metacarpal phalangeal extension at the digits 4, and 5, and that's going to give you an ulnar claw. But this is at rest, not while they're trying to do anything. An ulnar nerve injury, oftentimes you can ask them to close their hand and they can make a weak fist just because they still have the superficialis tendons in the flexor compartment that can pull on the middle phalanx. Here you can see a couple of the examples of a true wrist drop seen in this patient who actually has to hold up their forearm, which is probably indicating that this injury is up into the armpit itself, and maybe even a posterior cord injury. And then on the left side you can see an intrinsic minus, which is typically from median and ulnar nerve damages together. Or you can get this from a disease called Charcot-Marie Tooth disease, where there's going to be peripheral loss of myelination. Notice how the hand is flattened, giving you what's oftentimes called an ape hand when that arch gets flattened. The hand typically has two arches, just like the foot, and it can oftentimes get flattened out and have wasting of both thenar and hypothenar and intrinsic compartments, which makes the hand look very skeletonized. That's the end of section 16, which is discussing the nerves of the brachial plexus and nerve injuries of the upper limb. And in our next section, 17, we'll talk about the muscles of the upper limb and some of the tendinous involvements and muscular involvements with those structures.